and then, or B0, not BO. So take a minute to just confirm, or you can take the plate that has your license to just confirm so that it's accurate. And then input your correct email address, and then your correct ID number. Take a minute to confirm the ID number you have written there is the right one, because if the ID number is incorrect, also it will not be possible to upload for you. Now, once you do that, you should be able to just submit or register, and you will receive the meeting link in your email. If you don't receive the meeting link in your email, just redo again and use the same message that you used to pay to redo, and then just submit. And then you should be able to access this meeting seamlessly. Now, we have communicated before that this session is ChemLTB accredited, this webinar, and as a result, it will attract 3 CPD points on the part of participants, and therefore ensure that you meet the minimum requirements. And our minimum requirements in this case, we want you to be here for at least 60% of the time. Now, friends and team, our system captures your attendance on real time. It's able to transmit if you are here for 1 minute, for 2 minutes, or for whatever time that you will be here. And anything less than 60%, you will fail to receive a certificate. And consequently, you will fail to receive the 3 CPD points. We shall not be able to award you the 3 CPD points. So once again, I want to welcome you to today's webinar. Today's webinar is ChemLTB accredited. It will attract 3 CPD points if you meet the minimum requirements. And in this case, the minimum requirement is the participation time should be at least 60%. And then once we are done with the webinar, we shall be able to do a few quality assurance, and then we shall be able to report for you these CPDs direct to the ChemLTB portal. So your work will be to just log in and check if the points have reflected. So in that line, I want to say that we have been doing a TAT of around same day, but because of the increased workload, which includes reporting for all the participants, their CPDs, we shall ensure that we report your CPDs on the portal on time and go ahead and process your certificates. But you will realize that this will take longer, and you may receive your certificate either on the second day or on the third day. But this finds when we have self-reported. So we begin with self-reporting, and then we proceed to send you the certificates. So once maybe you don't receive your certificate on time, don't be worried. I think that has been occasioned by us taking a lot of time to report for you first, is when we send you the certificate for your own records and for your own reference. Having said that, ladies and gentlemen, we have members here who we are still not able to report for. So either your license is not up to date, that means that you have not renewed your license, or you have given the wrong details when it comes to your ID and your ChemLTB registration number, or you have not been able to sign up on the ChemLTB portal. So in the course of this presentation, we shall share with you the links that will allow you to register. So you will see the links on the chat box on how to sign up on the ChemLTB portal. You will receive the link on how to check your CPD points. So at your own time, just take your time and log in through those links so that we can move together. Otherwise, up to that point, allow me to invite all of us to today's webinar. And as you had seen in our poster or in our link. Degree in medical lab science, a master's degree in medical lab sciences. She has specialized in parasitology, and currently she's a student, a PhD student. If you can hear me, welcome very much. My name is Frederick Obade, and for purposes of this webinar, I will be your moderator. So Celine, if you can hear me, we can see your screen, and I want to welcome you to proceed.
Thank you so much, Frederick, and the entire colleagues for joining this productive webinar. We want to appreciate God for giving us this opportunity to have this program to learn. So today we are going to make a presentation on laboratory stool examination and its medical importance. So actually we'll start with a disclaimer that stool is one of the samples that has been ignored and most people really don't enjoy or processing stool. However, looking at the medical importance of it, it still has a lot of medical implication on our patients, and a lot still has to be done to ensure that our clients are healthy. So the outline of presentation, we look at the introduction, advantages of stool examination, collection of stool samples, microscopic examination, wet preparation of stool, concentration of stool samples, microscopic examination, and probably we are going to do an overview of the chemical treatment of stool. So in our learning objective, we are going to understand the significance of stool examination. Actually, why should we do this stool examination? Is it really important in our laboratory system? Then how to effectively collect stool sample for examination? We are going to look at to effectively learn how to examine stool macroscopically, then learn to conduct microscopic examination of stool sample, learn different types of stool concentration technique. Then we are going to do an overview of the importance of chemical examination of stool. So I hope as we learn this, it will be an interactive section and we are going to get something to implement in our day-to-day activity. So in our introduction, we see that stool is not just a simple waste as people think, but it has a lot of medical implication to our patients. So some stool tests can be easily used as a primary differentiation diagnostic for disorders such as gastrointestinal infection, malabsorption syndrome, and inflammatory bowel disease. So that's why we really need to look at this sample as a valuable sample when presented to us in the laboratory. So stool samples can be examined for leukocytes, for occult blood, which actually has been neglected in most of our public setup, fats, sugar, the reducing sugars, the pH, the pancreatic enzyme, the alpha-1 antitrypsin, calprotectin, and infectious causes such as bacteria, viruses, and parasites. So the stool should also be microscopically checked in terms of color, which is very, very important, consistency, quantity, shape, odor, and even the mucus, the presence of mucus in that particular stool sample. So as we continue, we realize that it is very important to get to know the normal amount of stool in adults. Actually, this sometimes is very important when you hear a child say that, Mama, today nimepupu mingi sana. So meaning that there is a required quantity of stool that is expected for an adult to produce. So when it comes to be less or excess, meaning it might have some pathogenic implication. So the required adult stool should be around 100 to 200 grams per day. And this actually also depends on the quantity of food you take. For example, when you are fasting, you don't expect to produce that much of stool. So stool is also composed of water, which is up to 75%, in digestive residue, food which is digested but not absorbed. It also has some bile, epithelial cells, secretion, digestive tract, inorganic material, and bacteria. So stool analysis determines the various properties of the stool for diagnostic purposes. So we go to definition. Actually, what is this stool we are talking about? So sometimes we call it human feces. Some people call it poo. Yeah, so this is what we call in stool. We call that stool in medical term. And this actually also causes problem in the initial stages because you realize that you could send us a client if you don't explain well to bring for you stool sample, then they will go home and come back with a stool. So, but to us right now with the current system we are undergoing, we explain to our clients and they actually know what stool mean. So feces in plural is of Latin word feces, meaning a residue. So it is the waste residue of indigestive material of an animal tract, which is expelled through the anus during defecation. So in children, the first stool that a newborn produce, it is always somehow greenish in color. We call it meconium, which is also very important. And we need to know that the first stool that a newborn produces is called meconium. So scatology or caprology is the study of feces. So that's just a few definitions that we have to learn today. So why stool? Why is doing stool examination? So this is a very important question that we need to ask ourselves as laboratory officer. Why should we do stool examination? So this is very important because it enables us investigate gastrointestinal diseases. So it enables us in detection of parasites, which can be in adult form, adult worm, the tapeworms, the larvae, and the ova. And this reminds me of something. Initially, there was a time a colleague of ours was complaining that the wife is anemic all through, he has passed through several hospital treatment, but no response. Then one of the laboratory officer, just in one of the rural basic laboratory, asked the officer if the wife can produce a stool specimen. And on detecting that stool specimen, it was realized that the lady was infested with rookworm. And that is something that can be treated very simply without going through years of hospital attendance. So examination of stool is very, very important because it enables us to detect some of these parasites that are very harmful to health. It is also very important in evaluation of chronic diarrheal diseases, like random diarrheal sample tested for pH, white blood cells, culture, or microscopy. Then there's also this sample of stool that we rarely do, but it is very, very important. A 48 or 72-hour sample examined for weight, fat content, carbohydrate, osmolarity, or chymotrypsin activities. So looking at the importance of stool examination, we also see that it is very important in evaluation of dysentery. And this actually makes us identify the causative organism that is causing diarrhea, which can either be amoebic or it can be bacillary dysentery. So bacteriologic examination is also important when we are doing stool examination, and it helps us in infection of bacteria such as salmonellosis or salmonella infection, Shigella, Vibrio, Yersinia, or Clostridium, which can be identified through culture of stool. So this is also very important. We still see that these organisms still exist, especially in the immunosuppressed group. So we still have to value stool culture as one of the laboratory examination of stools. So there are also bacterial toxins that are released by Clostridium species, And this can also be identified through a stool. So we also do chemical examination like occult. Occult blood test has been ignored, and it is one of the initial tests that help us in identification of cancer of the colon or carcinoma of the colon. So you realize that we go to this most expensive test, but we ignore the basic tests like occult blood that can be done in a level 1 laboratory. So those are key things that we need to look at as laboratory officers and find how best can we help our clinical team to utilize these samples to support our clients. So it is also very important in differentiating infection by invasive bacteria like Salmonella, Shigella from that due to toxin-producing bacteria like E. coli or Vibrio cholerae. So increased number of polyphonuclear neutrophil by methylene blue stain are seen in the former. That means they are seen in Salmonella and Shigella compared to E. coli or Vibrio coli. So we also have rotavirus, which is an examination in stool that is done for the children. And this is a common infection. This is a common virus that affect our children. So this can also be done in stool, and we can use electron microscopy, latex agglutination, or immunofluorescence or laser techniques. So those are the reason why, the importance why we do this stool examination. So because we want to examine this stool, it is very important for us to collect these samples. And when collecting these samples, something to note that you have to adhere to the observed universal precaution. And I believe we know this, like we need to use gloves. You need to be on your PPE. If possible, you have to be on your surgical mask. And we also encourage for stool sample collection, then you need to provide a tissue for your client, because remember, your client is going to go to the toilet to produce this precious commodity, and your client didn't carry a tissue. So there are chances that the client will use his finger and probably clean and touch the container, which is also going to be a way of avoiding or exposing you as a lab officer to risk. So you need to adhere to your universal precautions. So stool should be collected in a dry, sterile, wide-mouth container. And I want to appreciate, because there is a lot of development that has taken place in the laboratory setup. Initially, we used to give them the Vaseline containers. Sometimes they were given a matchbox, a matchbox tin. But right now we see we have standard stool collection containers, which are also very cheap. Yeah, they even have a cap in it. And they also have a spoon that help our clients to collect samples. So you really have to ensure that your client has the right container. So it should be uncontaminated with urine or any other body secretion. So during this time, it is your responsibility as the lab officer to have an opportunity and explain to your client the kind of sample you need. Explain to your client not to contaminate the sample with urine. Explain to your client. You need to ask questions if you are dealing with a female client, whether your client is on period, because there is also that blood. If it is in urine, it will be an indication of something. But now if your client is on period, probably that's just a normal phenomena. So you need to take your time and let your client know the quality of samples you want, because this is what will give you a quality diagnostic. Then properly named and always fresh samples should be tested, preferably within 1 hour of collection. So we always encourage that you label the container before you give to your client for IPC issues. So make sure it is labeled well. And it is also very important that you instruct your client not to interfere with the labeled, and make sure you process the sample within 1 hour. You know, sometimes we we request our clients to bring the samples, then we allow them to take long in the bench. So that might not give you the exact thing that you want. So samples may be refrigerated if delay in examination is anticipated. So when you expect that you are likely to delay this processing, then you have to store your sample in a sample fridge. Then a fixative may be used if specimen is to be transported to distant places. We can use formalin for preservation of eggs, larvae, and cyst, or polyvinyl alcohol trophozoites for preservation of trophozoites, cyst, and for permanent staining. And actually, I also believe that you are aware that we can also use transport media, especially when we are transporting samples for cholera. So that's something that you need to know. So something that is highlighted there, that 3 separate samples collected at 3-day intervals are recommended to detect all parasite infection. This is very key because this one now will help you. If you really suspect and you have very high suspicion that your client might be suffering from one of these parasites, then you can request for more samples. You can tell your client to bring a sample today, especially after waking up in the morning, then the next day, then the third day, to improve the predictive value or how to actually ascertain that these my clients do not have these parasites. I know that is not done in the common system, but it can be of good chance, especially to our clients who are admitted. It can be of good chance to ensure that when I declare my clients to be negative for parasites, my client is truly negative. Something also to note that one negative report for ova and parasites does not exclude the possibility of infection, because probably during or that portion of the sample that you took, that portion, because in examination we just do a sample, probably it did not pick up the parasite. So, and that is why we need to emphasize on this other method also. So when we are doing the macro examination, macro simply means you are using your eyes to see. You don't need a microscope here. And this is something that it's not very pleasing to look at this, but now because this is the work we are doing, and it is also very important to ensure that your clients go home satisfied, we need to come up with a culture of looking at this tool, using your eyes to look at this tool, yeah? You can put on a surgical mask to prevent the smell, put on your gloves, and then hold that container nicely and look at that stool, yeah? So the stool will be checked for color. Look at the color and document, yeah? I can remember during our attachment training, the people who took us through, they will tell us, document the color of the stool. What is the consistency, amount, shape, and the presence of mucus, the odor. How does this stool smell? And I believe with our theory, we mastered the type of smells of stool. So you need to document the smell, yeah? Then microscopic appearance of the stool can give a clue of the type of organism present. And those experienced parasitologists will tell you that if it smells like this, we suspect Giardia, yeah? Then the consistency. Normal stools are well formed. Then we can have diarrheal stool, we can have semi-formed stool. So you really have to indicate the consistency of the stool. So in diarrheal and dysentery, the stool are semi-solid or watery in nature. So the cysts have been mostly found in formed stool, the cysts. They are mostly found in formed stools, while trophozoites have been mostly abundant in watery stool. So color, the normal adult stool is brown due to the bile pigment, and the color of stool is affected by the type of food. This is very true, yeah. And I believe those who have children, sometimes your child tells you that, hey, mami na pupu ya green, yeah? So that means this person has been on vegetable for quite a long time. So it might not indicate any pathogenic indication, but maybe the type of food that this person is eating has led to the color of the stool. Also the drugs, some drugs that we take can also affect the color of our stool. So infant feces are yellow, green, and semi-formed. They are soft, yellow, green. So looking at the macroscopic examination of stool, yeah, we see that abnormal color of stool, we have watery, they like rice water, or we call it ricey water. So this has been associated with patients with Vibrio cholera. So when you see rice water stool, yeah, you suspect Vibrio. Then we have clay or white colored, that is obstructive jaundice or presence of barium sulfate. Then we have reddish color, that is blood from lower gastrointestinal tract, or somebody who has too much of beef consumption can cause that. Then black, we have bleeding from upper gastrointestinal tract. Sometimes we call it melena or iron or charcoal. Then we have green, that is injection of spinach and antibiotic. So blood and mucus, it's a case of dysentery caused by entamoeba histolytica. Then we have blood and pus cells, a case of bacillary dysentery that can be caused by Shigella, Campylobacter, or E. coli. Then only blood, diarrhea caused by Salmonella, E. coli, or Clostridium. The presence of adult worm can be seen in freshly passed stool. And that's why I emphasize on looking at this stool with your eyes. You can sometimes see the stages of ascaris. You can see Entobias vancularis, the proglottic of Tania species can also be seen. And that is why we need to look at this. So when we look at this picture, actually, it might be not very good thing to look at, but as a lab officer, this is why we eat anyway. Just look at it and examine that stool and give a feedback on what you have seen in the micro or the macro examination of the stool. And this will also help the clinicians understand what might be happening to my client. So when we go to the microscopic examination, so in this part here now we are using the microscope. We are using the microscope to look at our stool. And basically for stool examination, we use the lower power for examination, that is times 10, and now times 40 now, objective now become our higher power. This is very important. And with some supervision, we see some of us are now forgotten the use of the cover slips. It is very important that when you are doing a stool examination or a urine examination, ensure you use a cover slip. That will also protect your lens, and it will also prevent contamination of your lenses. So ensure that when you are doing your purchase, you buy the cover slips, even as we use the times 40 and times 10 of our light microscope. And ensure you report the presence of the parasites. We call them the leukocytes, very important. So large number of parasites, you can find them in clumps. They're in groups. So when you see the parcels in groups of greater than 50 cells per eye power, along with the macrophages and erythrocytes, these are typical of shigellosis, yeah? So that's a bacterial infection. So if you see a small number of parcels of less than 20 per high power field, when you see this one, now you can query salmonellosis and infection which are caused by invasive E. coli. So in amoebic dysentery, the cells are mostly degenerated. They look like ghost cells. They are old, yeah. So you can do that. Then leukocytes and erythrocytes are also found in about a half the cases of diarrhea due to Campylobacter species. So few leukocytes, that is 2 to 5 cells per high power fields, are present in cases of enterotoxigenic and enteropathogenic E. coli, and even cholera and viral diarrheas. Then we can also see the red blood cells during our microscopic examination. We can see amoebas, the flagellates, we can see the eggs, the larvae, and the cyst. And something to note that I would want to emphasize, for you to be an effective laboratory officer, then you need to have your job at the bench side, that indicates these things we are talking about. In my microscopic examination of stool, what do I expect? Yeah, you have to have a job that indicate for you your expected pathogens there, the red cells, how do they look like in a wet plate? Yeah, something like that. And that is going to help you even as you mentor and orientate your staff. As you mentor and orientate your staff, it will be really help you. Yeah. So looking at this, we have the direct wet preparation, and I want to believe that this is what we commonly do, and majority of us also have forgotten the use of iodine and its importance. But I would want us just to go back into it because it helps us now identify at a close range and differentiate these different amoeba species, the cyst that we see, and even the ova. So when we look at direct wet preps, stool examination for parasites, we can either use the saline or we can use the iodine. So we have the normal saline, which is 0.8%, is used for routine examination of stool samples, and it is used to detect the worms, the eggs, the larvae, protozoan, tropozoites, and the cyst. So in addition, it can reveal the presence of red blood cells because the solution being used there is isotonic. So you'll be able to see that. And looking at that flow chart, I believe you are seeing it very clearly. Yeah, so that's how it is. Just one drop of that mixed with stick applicators, and then good for helpmeet eggs, larvae, then good for motile tropozoites. Yeah, very key. So then using of iodine. So iodine is used to examine the nuclei of cysts and to stain the glycogen. So using of 1% eosine is recommended. So this provide a pink background, and that will help to clear the unstained object. Yeah, I just want us to appreciate this good work that we can do when we properly examine our stools. Yeah, we have the egg of tapeworm there, the Tania species. Then we also have some items like the chocolate-laden crystals. So we see some of these things in stools. Then we have the tropozoil of trichomonas. Then we have the red cells, the leukocytes. I want to see we are appreciating them. That is a saline wet mount stool on a microscope. You can see the larvae of strongyloids, Stachyralis, the eggs of Trichuris, the whipworm. Then you can see the oocyst of Cyclosporas, Tenacis. Yeah. So this is just good work that we appreciate when we examine a stool, which is a quality sample. So this is just also one of them in a wet prep. So we'll be able to get some of those pictures. So as I get into the next step of the objective, we have concentration techniques, which truly also have been ignored, yeah? Yet they give us the best, because when you have that one sample that has been removed and you want to check whether there is an infection on it or not, then you'll have to concentrate. Concentrate means that you want to ensure that you concentrate, you increase the amount of the parasite in this particular small sample that you have, yeah? So concentration techniques, this method enhance the sensitivity of stool examination by separating parasites forms from the fecal debris. So it will concentrate and separate the fibers, the debris from the parasite itself. So by the time you'll be going to microscopic examination, you are very sure that now I have the parasites. I know these techniques have been ignored because of their There are challenges and the technical procedures involved, but they are one of the best to ensure that our clients get the correct results. So if the number of parasites in the stool specimen is low, yeah, the number is low, specimen is low, the examination of direct weight mount may not really reveal them, and hence the stool should be concentrated, which is a possibility. Yeah, so eggs, cysts, and larvae can be recovered after the concentration procedures. Yeah, whereas tropozoans can get destroyed during these procedures because of the chemicals that are being used. Yeah, so we can either do concentration using formalin, and as you are able to see in the pictorial there, you are able to do that. You are able to do that. Yeah, you are able to do that. Like now you'll have stool that is 2.5 grams. Then you'll add it to 10% formalin. Then you mixed well. Yeah, so actually those who had an opportunity to practice this like I did, it's a very interesting procedure. You take your stool, your pea-sized stool, then you mix with 10% formalin, then you mix thoroughly. Then you'll have to leave for 30 minutes to settle. Then filter. You filter using layer of gauze or a wire screen. Then you take 3 mils of that filtrate, 3 mils of what you have filtered. Then add 10 to 12 mils of saline, 0.5%. Then you mix well again. Then you centrifuge at 2000 RPM for 2 minutes. That is very important because now it will make your parasites to settle. Then discard the supernatant. Supernatant means the upper part of your centrifugation product. Now you discard it. Then leave 1 to 1.5 mil sediment. Add 9 to 10 mil of formalin again, 10% to sediment. Add 3 mils ethyl lacetate. Then cap the tube and shake well for 30 seconds. Then you will have to centrifuge again for 1 minute. Then 4 layers will be formed. Then make smear from that layer. As you see, it is indicated there. So you'll have to make smear from that layer. And of course, you'll have to use your cover slip. Don't forget about that during examination. So concentration techniques are categorized, and I believe there are so many concentration techniques, but for the purpose of our learning today, are concentrated on the two, that is flotation technique and sedimentation. So for flotation technique, you utilize solution with higher specific gravity than the parasites, causing them to float to the surface while the debris sinks. So that's just the basic principle, that when I'm doing a concentration technique using flotation, then I will need a solution with high specific gravity. So this will make my parasites to float, and then other items that are found in the stool will sink. So I'll be able to pick my parasite up there in front of that tube, the centrifuge tube that we use. So the examples of this floating or solution with high specific gravity, we have the zinc sulfate. So we can use zinc sulfate flotation techniques or saturated sodium chloride flotation or the Shita sugar flotation. So we can use zinc sulfate, saturated sodium chloride. That means it is sodium chloride, which is more than 0.85. Then we can use the sugar. So for sedimentation technique, that's what I've explained prior. So in this case, we employ a solution with low specific gravity. So when the specific gravity of the solution is low, meaning our parasites is going to be at the bottom. So we can use formalin, ethyl acetate concentration technique, or formalin ether, or Biermann technique, which is specifically for nematode larvae. So this is just the flotation techniques and the sedimentation technique. So for the flotation, we see now the parasites are harvested up there using the cover slips. I know it's very tiny, but we are able to see. So we see the cover slips, then we harvest our parasites. Then for the sedimentation technique, we have the sediment containing the parasites down there. So we are going to put that just the way I've explained, and from there we'll be able to look at our parasites in the microscope and get to know them. So these are the parasites that we appreciate when we do this. Like we can see the various parasites there and the larvae. So these things still exist, especially for, despite the fact that they have been doing mass drug administration to school, but we still have these parasites. I believe because like in our system, if we do 10 stool sample, we have to get one with one of the worms. So if we intensify stool analysis, then chances are that we are still going to get these worms. And initially, I can remember they used to do stool samples for the pregnant mothers, but it stopped. It is not even there among their profile. Yet we see these mothers are eating soil. Some of them are eating charcoal. So probably if you see a mother who is pregnant and the HB is persistency low, then you can think of stool. Probably there are those parasites now eating into the blood system of this mother. Yeah. So when looking at the examination of stool, we have the normal stool. So when you have your stool, it is normal. It should appear brown, or sometimes it can be affected with the kind of food that the person had eaten. It should be soft and well-formed in consistency. Does not contain blood. Yeah. So this is a very key thing that we need to put in our mind. When you are processing a stool and you see blood, it is formed soft, well-formed soft, and then now it has blood, yeah? So that one has to come in very keenly, because you might be dealing with cancer of the carcinoma in the early stages because of the ulceration of the colon system. Now stool is coming out with blood, and now that occult test now become very crucial there. Then it should not have mucus, it should not have pus, it should not have undigested meat fibers, yeah. Harmful bacteria, viruses, fungi, or parasites. So the stool is shaped like tube. In our theory that we did in school, we know how the tube look like for the normal stool. So the pH of that stool is 7 to 7.5. So the stool contains less than 0.25 grams per dl of the reducing sugar. Then the stool contains 2 to 7 grams of parts per 24 hours. So that's a normal stool. When you are describing the chemical nature of the normal stool, that's a normal stool. So when looking at the abnormal stool, we have the stool is black here. You have received a stool sample, and then the stool is black here. So that's already an indicator what actually might be going on. This stool is black here. So that one is very key. Red, it can be red, white. You see a child just producing a white stool, yeah? Yellow or green. So the stool is liquid or very hard, yeah. In fact, the client can tell you that I'm really finding it difficult to go to the toilet because I produce really hard stool, yeah. Sometimes the stool become too much, yeah. Even you as an individual, you go to the toilet and this particular day, what you are producing or what is coming out is too much. Yeah, so that means there is a problem somewhere. Yeah. Contain blood, mucus, pus, and digested meat fibers, harmful bacteria, viruses, fungi, or parasites, and low level of enzymes such as elastase. So when you see this, it indicates there is a problem because, for example, the reason why we look at this enzyme, like the alpha-1 itraprisine levels in stool, it is important for diagnosis of protein losing enteropathy, yeah, which is a condition where excess protein is lost into the gastrointestinal tract. So it indicates that there is a leakage in the gut, leading to due to elevated inflammatory bowel, because enzymes are basically proteins, yeah. So when we realize that now enzymes are coming into stool, meaning there is a problem in the digestion of the protein, so there has to be a gap in the gut, and especially that part of the gut that is meant to digest this protein. So we also have the
Celine, I think we lost you.
This is crucial for differentiating. Sure.
You are back. You're back.
Oh, sorry. Okay, sorry. So I was just saying that I don't know whether we picked up this part. I was talking about the enzymes in stool. Did we get
please.
that? Good,
Yes.
thank you. Yeah, so my next step was I was talking about the calproteins. So calproteins also is very important when we identify these as part of the chemical examination of stool, because they are crucial for differentiating between inflammatory and functional gastrointestinal disorders, and particularly the inflammation bowel disease and irritable bowel syndrome. So when we see these calproteins in stool, it gives us an information there that these clients might be suffering from inflammatory bowel disease or irritable bowel syndrome. Then we also have the pancreatic enzymes that sometimes we can find in stool. Yeah. So particularly the elastase 1, which is crucial for diagnosing exocrine pancreatic insufficiency, which is now, it will give us an indication that this client might be suffering from exocrine pancreatic inefficiency and assessing pancreatic function. So we have other abnormal levels of parasites, of enzyme, especially the pancreatic enzymes. They indicate chronic pancreatitis, citric fibroids, pancreatic disorders, and the rest. And that is why it is very important for us to look at this. I know this is something that is rarely done in our public sectors, but if we can look at this chemical abnormal nature of stool, then it can give us a clue, because especially in this era that we have high level of cancer, especially for the colon, we can identify early cancer diagnostic through occult and some of these enzymes and even blood in stool. So when the pH of the stool is now less than 0.7 or it becomes greater, then we say this is abnormal, because we said there that normal stool has a pH between 7 to 7.5. Then contains 0.25 grams or more of sugars, the reducing sugars. I believe we know the reducing sugars. So if in normal stool, it should be less, but now in abnormal, it is between 0.25 or more. So the stool contains more than 7 grams per 24 hours of fats there. So that is also a very key indicator. When we see fats, examining fats in stool sample is a valuable diagnostic tool to assess fats absorption or identify potential digestive issues. Like, for example, when we are in stool, we learned about the stachorrhea, the presence of fat in stool. And this may indicate a problem in the pancreas, the gallbladder, liver, or the small intestines. Yeah, so for the reducing sugars being found in stool, that is just an abnormality in the absorption of the carbohydrate. So I think we will still appreciate that it is very important for us to do chemical examination of stools. So as we continue with this, we see increased fats is associated with malabsorption syndrome, like obstructive jaundice. Yeah, so somebody who might be suffering from obstructive jaundice may have malabsorption of fats. Non-tropical spree or coliac spree, the Crohn's disease, the cystic fibrosis, the Whipple disease, enteritis, and pancreatic disease, then surgical removal of section of the intestines. You see that some condition may involve the removal of some section of the intestine. So this might also result to this. And I know our clinical counterparts, they know of these diseases better than I know, like the Whipple disease, the cystic fibrosis. Then we have occult blood, and I will encourage us, because this is a test that can be done even in a basic lab, may indicate diverticulitis, ulcerative colitis, which indicate that there's some ulceration in the colics. Then we have diaphragmatic hernia, adenoma, which is part of the family of the cancer. We have the CA colon or the castrium. So when we do this occult blood and it becomes positive or reactive, it's a clear indication or a screening that this client need to be attended to, and it can lead to early diagnostic of this CA colon. Yeah, increased pH, alkaline, yeah. So when we do a chemical analysis, then we have increased pH. So our stool is more alkaline. That means it is below 7. Then we suspect that our client might be suffering from colitis, antibiotic use, villus adenoma. Then probably this client might have been on excess protein in the diet. So when we have decreased pH, that means it becomes, alkaline, I meant above 7.5. And now when it becomes above or below 7, now it decreases acidity. So we'll have carbohydrate malabsorption, fat malabsorption. Then it will also cause disaccharides deficiency. So that is also a clear indication. We see colitis there, very important. We have villus adenoma. Yeah, so we really need to come up with this, yeah. So as I finish up, I just did a screenshot of this. Like, we can also prioritize stool sample for culture, which is very important. You've done your wet preparation, you've done your concentration, you've done your chemical test, you've done your rapid test like salmonella. We are able to do salmonella antigen tests, but still, you are not leading somewhere. You can advise for culture, and we have facilities that do culture. Like Kisumu County, we have JOTRH, and we have a specialized microbiology lab there that is able to do for you culture as an effective course. So we can also request for culture before we put our client into unnecessary antibiotic. I know you know the challenges that are also with antibiotics. So a stool culture is done to find out if bacteria may be causing the infection. So we can use culture media like McConkey's agar, so inhibit most of the gram-positive organism and differentiation between lactose fermenting and non-lactose fermenters. We can also use the xylose lysine deoxycholate, XLD agar. So these are selective medium for the isolation of Salmonella shigella. Then we have the TCBS agar. This is excellent selective media for the primary isolation of cholera. Yeah, so then we have the sorbitol maconche agar. So contains sorbitol instead of lactose. So E. coli 0.157 produces colorless colorless on this because it does not ferment sorbitol. So this media is used for screening this. And I believe the microbiologists that we had today, we have in this forum, understand this better. So culturing of sample, the stool culture on selective media by striking a loopful of stool specimen. You just strike on that culture plate. Then the stool macroscopic examination may aid in selecting the suitable culture media. Yeah. So that's also give us the importance of using this macro, looking at using your eye to see that stool also will guide you on which particular media to use. And I believe probably you'll have done other things, including gram stain, yeah, to help you on what kind of media to use. So after the identification of the microbe and antibiogram should be done. So as I finish up, you still find patients with intestinal obstruction with worms. Yeah, so that's ascaris. So sad. You see somebody having an intestinal obstruction, and then this person is taken to theater. Then what come out is just colonies, or how do I call it? Infestation of worms, yeah. And this is somebody probably who have been going to the hospital setup. So as the laboratory officers, we can appreciate the importance of stool samples and also guide our clinical team on how best we can use these samples to help us in the medical support of our clients. And I think with that, I come to the end of this presentation, and over to you, Frederick. Thank you for listening. Over
Wonderful,
to you.
wonderful, wonderful. I think there's a saying that says that it gets better with time or with age. And I think, Celine, your experience and is very clear here. A lot of positive comments from some saying they're your colleagues, and many of us here, we are here in our thousands, and you can see people are saying good presentation. They have really learned a lot. So excellently done, Celine. And I just want to say that we have many questions, and I'm sure that whatever we are learning today is applicable in all levels of our practice as medical lab officers. So there are very many questions, and I just want us to get a few, and I will read, so maybe you can note down and you can respond. So I'll start with Collins Muleshe. You did not mention this, but kindly mention on storage duration and condition of stool samples after examination.
You want me to respond now?
Yes, you can respond.
Okay.
There are those that will just respond.
Okay, thank you. That's a good question, but this one depends on the lab standard operative procedures and agreement, storage of sample after examination. Some will say we do it for 1 week, some say 1 day, some don't store. So this one is not cast on stone because it depends, especially with the accreditation, each lab is expected to come on with their duration of storage. However, I do encourage, if you get a significant thing, then you can fix that sample and store it forever, especially when you are using it for educational purposes. You can also stain and make smears so that when students come to your lab, you can use the same sample to to teach your students. Thank you. I think that's the best I can answer that.
Thank you. Andrew Onyango, kindly ask for me how the QC is achieved to ensure that the stool report being given out is of utmost credibility and reproducibility. Is it important to report things that are not seen in the stool wet prep, such as fat granules?
Oh, thank you so much. Actually, let me talk. Those are two questions. Yeah. So the first question, QC in stool is a bit challenging because these are things that you see, and that's why I talked of the job aids that is pinned at the bench where you are working, because when you see something that you might think might be significant, you can refer to your job aid. And then also you can consult a colleague for review, because sometimes we see things, especially the macrophages, sometimes confused with the tropozoite. So because a macrophage will be moving, and then the tropozoite also might be moving also actively. So you can consult. So we might not have a definite QC, like for example, we do for malaria. And also, if you have the slides that you are prepared, or you have your samples that you have fixed and stored, it can also help you as a QC. And then the next question, yeah, looking at the fat granules, probably you will see whether they make a significance. And if they do, it will be very important to report, because that will show us that there is a malabsorption of fat in this particular body of this client. Thank you.
I think, thank you. Jason Mundu, I think this is the Lancet country manager. He's saying we can do interlabs to see if you are okay. Okay.
That's true.
Thank you, Jason, for that. Now I'll ask their next question, and I think they are a bit interrelated, so you can just see what to say. So Edward Magero, what is the significance of reporting stool color? And then Benedict Wachala, based on the order of the stool sample, some are very offensive, some moderate. Is it true that parasitic infestation are offensive? Also, H. pylori is becoming more common even under 5s. What could be the reason for this?
Okay, thank you so much. Yeah, it is very important to report the color of the stool, just like I was said, yeah? We have the color of the stool that will indicate there is some blood, or probably there is some digestive blood in the system, like blood red, yeah? Or probably it will say that maybe it is green, yeah, or yellow. So it is very important, because we said normal stool is brown because of the presence of bile. So when I'm getting a black stool, meaning there is some intestinal bleeding taking place, and this might be causing a problem, or probably my client is on a particular drug. So it will make us to probe more about that. So when it comes to H. pylori, actually, I didn't consider that, but it is becoming more common. But probably it depends with the method you are using. If you use the strip one, actually the positivity rate becomes very high. But now if you use the stool, the positivity reduces, yeah. So I might not be able to give this, but you know that H. pylori actually also causes the ulceration of the GIT, yeah. So probably somebody will help us here, especially those who have done microbiology. They'll be able to understand that question well.
Thank you, Sally. I'll read something more. Sylvester Kiplangat, is it a must that we quantify the number of parcels when reporting? And then Frederick Anyanga, please say something about bacteria in stool, especially identification in wet prep, please.
Okay, thank you so much. It is very important to quantify parcels in stool, yeah, because we said pastel, actually, the presence of parcels, mucus indicate an abnormality. And we said if it goes beyond 50, actually it is driving us to another test, which might lead to requirement to request for culture. So when we see a bacteria in wet prep, actually we'll just see things moving so many, but we might not be able to identify. So at this point is now when you will think of things like gram stain, which will help you whether it is gram positive or gram negative. Then from there, it is very important further to do a culture. So this culture is now what will help you in identification of this bacteria, but you cannot identify what kind of bacteria you are dealing with in a wet prep. Thank you.
Just on in the same breath, I think I've lost the question, but let me just proceed. How do you, this is Johnson Omboga, how do you determine the fat content in stool? And then Alfred Ojuaka, are starch granules significant? If so, what could be the cause?
Okay, thank you so much. Yeah, so there are specific tests that are used, and maybe if you go to the market catalog, you'll see there are specific tests that you can use to do fat content in stool, different, just like we have different tests, like we have salmonella for stool, H. pylori, we have also fat contents for stool. Yeah, so you just go to the catalog of laboratory suppliers, then you tell them you want to determine fat content in stool, then they will give you a kit that is going to help you do that. So when you see starch granule in stool, it indicates there is a malabsorption of carbohydrates, yeah. So probably you'll have to do some more examination to see exactly where the problem is. Thank you, Ojuaka, for that question.
Okay, so I'll proceed to the next. When you talk, this is Martin Jogona. When you talk of 3 samples, which is the most preferred sample? And then I'll read another one from Irene Chebet. Okay. Sorry, so let me just read it. This, I had an itchy anus after delivery and also bleeding. Could it be I'm infected with a parasite or is it hemorrhoids?
Wow, thank you. For this itchy anus, it can be parasitic because we know there's that parasite, Enterameba vancularis, yeah, that is able to cause that itchiness of the anus. But probably we will not want to assume, yeah, so it is very important you go for a medical checkup, whether it can be fibroid because of the bleeding you are talking about, or is it parasites. So those particular 2 tests will be able to assist you. So when we talk about the most preferred sample, when a client comes to your facility, it will be so sad to tell your client, go back and come tomorrow, bring for me your morning sample. Yeah, so it is very encouraging you have the 3 samples, but you can let your client, if your client is able, we have some clients who have trained themselves, they can only produce stool in the morning hours. So during the day, they are unable to produce stool. But if you get a client who is able to produce stool at that time that she comes to the hospital, then it will be of good order if you pick that sample. Then you can encourage your client to bring the sample, the first sample in the morning, because you realize that we also don't want to skip this sample for 24 hours. So we want this sample to be processed in 1 hour. So the client can bring the morning sample and then the next day morning sample. And then if you examine these three in a better way, if that client has an infection, then you'll be able to identify the infection. Thank you.
Thank you. So I'll read from Kevin Ochieng. How would the amount of stool be of clinical importance to the lab, yet only a small portion of the sample is required for analysis? And then Bernard Onduru, stool from women who consume a lot of odongo also looks like udongo and also had like udongo. What would we suspect in such specimen? Okay.
Thank you. Let me start with the second one. And actually, that's what I say, that I don't know, maybe somebody can do a research. It is still very important for the pregnant women to be done for stool analysis as part of the profile, because they take soil. In fact, some of them literally dig the soil. Some of them buy. Until now, soil can be bought in the market. So such a stool will look abnormal, and that is why the color of the stool now becomes very significant in the medical system. And in such stool, because this is soil and we have soil helminths, chances are that we are likely to find a parasite in this stool. Yeah, so that's why we need to be very keen and examine that stool. So I said that the amount of stool will be clinically important, and you will realize that that amount of stool will not even reach the lab, because when you are sending your client for a stool sample, you instruct your client that you just need a pea size. In fact, it has a spoon. Utamwambia, I just need one of this spoon. But now, it is the work of the clinical team to inquire from their patients what amount of stool they produce, because the amount of stool produced will indicate whether this client is having diarrhea, or this client has an infection that might be causing all the stool to come out in that amount. So it might not reach you in the lab, but this is for the clinical team. It is very important for them to inquire about this. What amount of stool, and even the frequency, very, very important. Thank you.
Thank you so much. You are handling the questions very well. I can read a comment from Helen Ogola. She says, Dr. Helen says, very informative presentation. I believe we are refreshing ourselves on stool, MLOs, and also gaining new information, sharpening us for quality diagnosis at our diagnostic sites. Thank you, Dr. Helen. Thank you so much. Dr. Helen is the CMLC National Caucus chairperson. Thank you so much, Dr. Helen. So I'll read the next couple of questions, Celine, if you allow me.
Yes.
And one is from Lawi Mwangome. He is asking, concentration techniques are the best. One of the best techniques is Kato, especially for geohelminths. My worry is it realistic to use such techniques, especially if you have 100 samples per shift? How can we utilize the concentrated techniques without undermining our TAT and overburdening staff? And then I'll read the next one from Derek Mwenda. How do we measure the pH of stool, like in the case of differentiating between types of dysentery? How do we come to know one is basic and the other is acidic? Thank you, Derek.
Okay, thank you so much. Those are good questions. Okay, I left up the cattle concentration technique because of the cost implication, and probably because it's mostly used in research setup, just like the person who is asking the question is saying. So some of these techniques are good, but they might not be cost effective in our system. That's why I left it out. Concentration techniques are still the best. And actually, things to do with TAT, it depends with what you tell your client, because, you know, some of us, we lie. You know very well that your concentration technique that you are going to take is going to take 3 hours. Then you tell your client 30 minutes. So just explain to your client that I'm going to do this test. This test is going to take 3 hours. So your client will be very lenient and either to wait or come back for the results. I don't want to believe that when we do concentration techniques, we are overburdening the officers. No. Because if I have a client who comes to the hospital barely every month because of just one particular problem, why should I just take 3 hours and help this client so that this client don't come back to the hospital again? Yeah, sometimes we overburden ourselves because we like shortcuts. So if we avoid shortcuts, then we'll be able to even reduce the workload in our hospital setup. For the pH, we have pH meters and they're in the market. When you are doing your orders, you can order from the lab suppliers, which I believe we have some of them in these forums. They will be able to guide you on the best to use. Thank you.
Thank you so much. I can read the next couple of questions, but allow me to read this comment from Tunje Ruben. Advise mothers with the urge to take soil to see clinicians because it's a sign of some mineral deficiencies. Okay, thank you. I can see a general concern on Gene Expert. This is tool that is used for Gene Expert, but this is in my under microbiology friends. We shall handle it at the right time. So just keep the question on Stool. I'm seeing a lot of concerns. We have taken that concern, and we shall prepare a presentation to handle that concern. So to you, Celine,
yes.
Can one consider anal swab for microscopy, just like we do for cholera, in cases where the patient cannot produce stool? This is from Angeline Ochana. And I've also seen a question asking whether we can get stool sample from diapers. I can't remember it was from who, but you can address that. And then I read the final one from Anthony Letting. Can a patient having a bacterial infection, yet pus cells are absent in stool sample?
Yes, you're done?
Yes.
Thank you. Yeah, we can use anal swabs. Very important, especially for the children. We also have bedridden clients. So if you have somebody who is effective and is able to collect this, it will actually give you the best because especially the early morning anal swab, we have some parasites that has the ability to migrate to the anal region. So we'll be able to capture them there. Yeah, for the diapers, I may say yes, I may say no, because it depends. You realize that the diaper also has the urine, and we said urine is a contaminant when you are doing stool analysis. Yeah. So instead of taking a stool from diapers, why don't we take from the anal region? It might give us a quality results. So somebody is saying somebody might be having bacterial infection, but now no parcels. Not all bacteria are able to produce this parcel. On the other hand, we cannot really say that a client has a bacterial infection until we test or we do a culture. So I'll be able to answer that way. Thank you.
Okay, thank you. Thank you, Salim. That's very much in order. So I'll bring more questions. This is from Danson Murimi. How do macrophages appear under a microscope? What features will I check? And then Lawi Mwangome still, please explain the pathological significance of cysts of E. coli as you report your stool analysis. We can take those first, Celine.
Okay. So looking at the the macrophages. So macrophages they are engulfing cells. So when you see them, they can, they look like they are big, and they look like they are engulfing something. Yeah, so that's what I can say. Some of them you can see they are motiles. Yeah, so that's how I can explain it. But if you see it in the microscope, you'll just see that this is a macrophage because it is kind of coming to engulf something. And then somebody is asking the cyst of E. coli. Yeah, so when you want to identify the cyst of E. coli in stool, then you will have to know how many nuclei do you expect in an E. coli. So that's why our job aids become very, very important. You have to know how many nuclei. For example, in E. coli, we have 8 or more, while in Entamoeba histolytica, we have 4. So those are key things that you have to look at when you are doing examination of stool. So I'll still refer you to your job aids. So have these job aids in your wall, then it will help you to distinguish these things. Thank you.
Thank you, Celine, for that. Can see many concerns, but we'll just try and cover. So I'll read this from Esther Kimani. How should we report bacteria seen during wet prep microscopy? Why do we get yeast cells in stool samples microscopy? So that's the first one. And then I'll read from Jaffred Machika. During microscopic stool examination, wet prep, do you see some tiny rod-shaped motile particles? Are they bacteria? And are you supposed to report them, or should they guide you to proceed and do culture and sensitivity? Otherwise, thank you for the presentation. Very audible and informative. Thank you, Jaffred.
Thank you so much. Hey, so the yeast cells, yeah. So when you look at the yeast cells in stool, probably there is a contamination. And that is why how you advise your client on the procedure is very, very important. So they might not be really of significance unless maybe the clinical features indicate an infection with this. So it might have been a contamination. So bacteria in stool, like the person who is saying the motile rod things, that is probably bacteria. But just like I said, it might not be very, very prudent just to conclude bacteria because you don't know which one. Yeah, so it can be a good indication to say bacteria presence in stool. However, it's advisable you proceed for other tests so that we also create room for the microbiologist to have work to do. Because you cannot offer treatment by just the presence of bacteria in stool, because we know stool is not a sterile samples. So you expect bacteria in stool. But now, if you feel that this might be a pathogenic bacteria, then you can do other tests that will give an informative decision. Thank you. Over to you, Frederick.
Thank you for that. Maybe I can read the next couple of questions. This is from, what is the diagnosis? It's an anonymous attendee. What is the diagnosis of black formed stool? And then I can proceed to the next one, Bernard Onduru. At what time should we collect stool for occult blood tests? And then I can read the last one from Anita Kimotho. How can one differentiate between amoebic versus bacillary dysentery?
Okay, thank you. I think I gave in a brief definition or differentiation between amoebic and bacillary. So when we see blood and mucus, it is a case of dysentery caused by entamoeba histolytica. But now when we have blood and pus cells, I believe we all know how to differentiate between mucus and pus cells. The case is bacillary dysentery, and this can be caused by Shigella and Campylobacter. Then I think that is answered. Then when we come to black formed stool, there is a probability of already digested blood in this stool. Actually, in stool, you can see whole blood or digested blood. So it is a diagnostic that there is something in the GIT that is causing blood, and this blood already has been digested in the system. Occult blood, just like I said, we can do morning specimen, but if a client appear in the facility, collect the sample, quality sample, and then you'll be able to get the report. Thank you.
Thank you for that. I'll pick the next couple of questions. Monica Wanjero. When is the right time? I hope this is someone else had still asked. When is the right time for collecting stool sample for a patient who is having itching characteristics around the anal area? And then this is from Alex Oirere. I want it clarified. In saline stool preparation, can we emulsify stool with saline in a polypot? Then using a pipette, we pick 2 drops and examine. Instead of picking a small amount, how sure are we that the portion left has ova and cyst, and the portion picked missed the cyst and ova? Was the procedure developed when we were using improper stool containers like matchboxes, which need changes? Maybe we can comment on that, Celine.
Thank you. And I believe we can also comment on the chat box. Actually, in laboratory, there's what we call the SOPs, standard operative procedures. And I will ask myself, how sure are you when you emulsify in that container? How sure are you that you are not leaving the parasites at the bottom when you use a pipette to pick? I think the procedure that we were taught that when you are brought for the sample, look at that sample, use your eyes to see, then pick the sites that seems to be abnormal. So you will go around, you have an applicator stick, yeah? You have an applicator stick, check the sites that seems to be abnormal, pick them. Then emulsify in your slide. Use your cover slip, then examine, because there is a possibility also, yeah, as you emulsify in the containers, chances are that you will leave the parasites at the bottom, unless maybe you want to concentrate that sample. Yeah. Then
Thank
for
you.
the itchiness, for the collection of sample, for the itchy anal, morning anal sample is the best. Morning anal sample.
That's clear, Celine.
Yes.
Bernard Nyango, in reporting stool under microscopy, are we supposed to quantify, or we should just indicate whether seen or not seen? And is it necessary to report things other than ova and cysts microscopically?
Yeah, that's very good concern, yeah. For us, actually, in the current laboratory system, it may be very important for you to do some counting, though it might not make of any significant, but now it gives you the level of infestation. For example, if I'm handling a patient, then I'm just able to see 1 ova of hookworm. Then I see another patient, then I'm able to see 10 of them. So the one that has 10 has very high infestation of these particular parasites, yeah. So it will help the clinical team on how best they can manage this client. And especially, this client can also be reviewed after treatment. You can call for another sample and review whether the parasites have been killed. So that's what I would say. And then sometimes you get to realize that there are different types of parasites you are seeing. So there is mixed infection. So it is also good to report and also indicate which one of these mixed infection is dominant. Yeah. Was it only one or there were two questions?
That's fine. That's fine. I'll read a comment from someone who's anonymous. I wish you told us your name. Outside of parasitology and the GI tract realms, there's some studies published in JAMA November 8, 2024 that suggest that specific metabolic compounds found in stool differ between individuals with and without endometriosis. These differences may help in non-inversely diagnose the condition or guide new therapies. The reason as to why I'm bringing this here is that as lab scientists, we need to broaden our perspective and recognize stool is one of the most underappreciated yet information rich. So that's just a comment. Thank you, the anonymous attendee. So team, there are a lot of questions, but let me read this from another anonymous attendee. In clinical settings, where stool OC results are negative and H. pylori tests are also negative, yet symptoms persist, how justified is it? How justified is empirical treatment, especially with antibiotics or PPIs? What are the risks of over-reliance on empirical management without clear microbiological evidence? And how can labs guide more precise diagnosis in such cases? So I think that's just a comment. And maybe I think this is why we are doing these CMEs. And wherever you are working, friends, we are doing this to just change the practice, borrow best practices so that even our clinicians, in fact, Dr. Helen said that with all this expertise, let us conduct CMEs amongst ourselves to build us professionally. Also try to extend the knowledge to the clinical team. This presentation will automatically change the clinician's mindset for better patient management. So I think there are many questions and concerns, but as you can see also, time is not on our side. And we want to appreciate, we are here in our thousands, so sometimes it may not be humanly possible to handle everything, but we shall be able to just have more of these sessions so that we can learn and also so that we can improve our practice wherever we are. And maybe I can just read the final one, Celine, then you can give your final remarks. From Mary Baraza, at what point is a patient supposed to do a colonoscopy after having blood in stool, probably after lab tests? So maybe we can just read that and then you can give your final remarks.
Thank you so much. It is very important to do it immediately because this indicates that there's a problem, and the earlier you identify the problem, the better. For my closing remark, I want to appreciate all of us for taking this opportunity to listen to me. And I also want to appreciate my mentors who are already here, like Dr. Helen, my colleagues, Joseph, Osea. And also I want to appreciate the LMSK for giving me this opportunity. I know as time continues, we are going to learn. To the laboratory officers, especially those who are still working on the bench, actually, it is good to value your work and to appreciate all samples. I believe with this presentation, we have realized that as much as we have ignored stool, it is one of the valuable samples that we have in the laboratory. And with that, I want to wish all of us a pleasant weekend. Thank you.
Thank you so much, Celine, and all participants. It was such a pleasure to host you here, and we don't take this for granted. We are sure that we are attending so that we can change our practice. And as you can see from many of our senior colleagues, there's a gap, a big gap between the upcoming generation in terms of even microscopy. And we are hoping that the senior colleagues will take it upon themselves when called upon on such platforms like Selin, and be able to just disseminate what they already have. Otherwise, I want to take this opportunity to say that we were not able to go deeply into maybe the stages of the parasites and different and maybe the how they appear on the microscope. And as Selin has rightly said, this is very broad. We are sure we shall do another session, and we shall be able to bring in another presentation to just cover most of your concerns. Otherwise, from us, we want to say thank you for finding time and for joining. And I just want to say that for those of us who merit 60% of their participation, you will find these CPDs already uploaded for you within 24 hours. But you shall give us more time to be able to send you the certificates. That is maybe on the second day, we shall work and send you the certificates. Otherwise, from us, we want to say thank you. Until next time, it was a pleasure to host you today. Thank you so much.